All right, we have a 45-year-old male, ASA1, forgoing a left knee arthroscopic procedure. We're gonna go ahead and out in the waiting room, we're gonna give an anxiolytic, which is gonna be 2 milligrams of Versed, 2 ml. I'm gonna go ahead and hook up all the vital signs in the patient: blood pressure cuff, SpO2, train of 4, EKG, and we have our end-tidal CO2 attached to the BVM, and we're just always gonna go ahead and check to make sure our suction is working once again. Now we're gonna go ahead and make sure the APL valve is a minimum. Our flows are up to about 5 to 8. We're gonna pre-oxygenate the patient. Sir, if you can go ahead and just take some real nice deep breaths for me. We're gonna do this for about 5 minutes. Having extra oxygen is gonna help us in the beginning part of our procedure. I'm gonna be, meanwhile, checking another blood pressure, looking at our baseline blood pressure, heart rate, and looking at the end-tidal O2, making sure it's 80% or greater. After about 5 minutes, it's been above 80%. We're gonna go ahead and begin giving induction medications. First, we're gonna give an opioid. We're gonna give 150 mics. Patient weighs 75 micrograms, and that is 3 ml. I'm gonna give 1 milligram per kilogram of lidocaine, which is 7.5 ml for 75 milligrams. This will prevent the sympathetic response and prevent some pain at the injection site of propofol. And then we're gonna go ahead and give 15 ml or 150 milligrams of propofol, which is 2 milligram per kilogram. Go ahead and keep taking some deep breaths for me, sir. Okay, the patient's no longer breathing. I'm gonna go ahead and turn the APL from minimum to 25, and we're gonna go ahead and begin bag mask ventilating. Sir, can you open your eyes for me? Checking lid reflex, he's not opening his eyes. I do have good chest rise and a good end-tidal CO2. We just wanna make sure that the patient is able to be bag mask ventilated prior to our rocuronium or paralytic. We're gonna go ahead and check the train of 4, and we have 4 out of 4, okay? Now we're gonna go ahead and give 50 milligrams or 5 ml of rocuronium. We're gonna continue ventilating the patient for 60 seconds to 2 minutes to make sure the patient is completely relaxed and that the vocal cords are relaxed. Okay, we're gonna say it's been 2 minutes, and then we're gonna go ahead and intubate the patient. But we're gonna check train of 4 one more time. And it says 0 out of 4, so we are adequately paralyzed. We're gonna go ahead and intubate with a Miller or 2. Get the intubation tube ready for me. Go ahead and take a look. All right, I have a Cormack-Lehane view of 1. I have good passing through the vocal cords up to the black line. Go ahead and pull the stylet for me. We're gonna inflate the cuff. And then we're gonna go ahead and make sure we have good chest rise. Good chest rise, good humidification in the intubation tube. We're at 22 at the lip. I'm gonna go ahead and assess lung sounds. Sir, could you go ahead and assess lung sounds for me? I wanna squeeze the bag in the epigastric. Right upper, left upper, and left lower. We have good sounds in the lung sounds, nothing epigastric. Okay. We're gonna check ventilator settings, change to automatic mode, turn down flows to 2. Sevoflurane is gonna go to 2%, re-hit our blood pressure, and now we're gonna go ahead and tape the intubation tube. Make sure the eyes are taped, which we will typically do prior to laryngoscopy.